has a history of something, or they have a clinical exam that's concerning. So I usually don't do anything beyond what we would clinically typically to screen for lymphadenopathy unless they've had a diagnostic test or I'm doing a clinical trial.
Yes, we're doing Sjogren's trial now, and it's interesting. Two things I want to clear up is that in the Sjogren's criteria, when we say they're SSA positive, what I read was that they had to have row 60 positivity and not just row 52. Is that true?
In our diagnostic criteria, that is not true. The clinical trial may have been structured that way. So row 60 alone is more specific for Sjogren's. But row 52, dual row 52, row 60 have more severe disease, and row 52 alone positivity, although it can be seen in other systemic rheumatic diseases, indicates a more severe Sjogren's if it's single positive. So that may have been a criteria of this study, but for our classification criteria, it's either row 52 or row 60.
So good. And secondly, it seemed like in the studies that we're looking at, they're excluding a lot of the more serious Sjogren's components. So they're just picking the ones that they think, I guess, are going to be the easiest to determine, which kind of bothers me when you're looking at trying to help these patients, but yet the studies which are going to be advertised and have commercials for, they really selected their patients. Do you see that?
In the clinical trials, yes. So and then this is one of the questions in the chat too, so I'll talk about this, like peripheral neuropathy, for example. Those patients are burdened and want a therapy, but a lot of these clinical trials are excluding that domain. Or interstitial lung disease, that's frequently excluded. Not all trials, some do all 12 domains, but some are excluding these. And so then you question which patients these findings will apply to. But there are some drug companies doing trials in those spaces specifically because of the call and the need to understand those patients. Good, thank you. Okay, so shall we move on to the next? Okay, we gotta go. All right, so next talk, I have a pre-test to scan. So if you wouldn't mind getting out your phones and doing your pre-test. Okay, I'll use my one eye to look around the room. I picked my strong eye. We're still doing. Okay. All right. Okay. So here we go. Now we're going to get into, so these are sponsored or supported talks, and so I'll talk about drugs, but I'll give really interesting clinical pearls, I think, about Sjogren's as well. So this one is supported by Novartis, activity provided by academic CME. These are my disclosures. They're not different from the previous. I think I consult for most companies because there are so few people who do Sjogren's. Here are the learning objectives. We already talked about the pathogenesis of Sjogren's, but now we'll jump a little bit into ianalumab and talking about how it might have a role as a disease-modifying agent. So this is what we're going to talk about this time. So this talk, we're going to focus on failures in Sjogren's and why that may have been, and then why we're seeing successes now to understand what to expect from these clinical trials. You know, what are we going to get for our patients? I will introduce ianalumab, what it is, and then I'm going to walk through just common clinical algorithms in Sjogren's, just like very practical things to use in your day-to-day clinic, using ianalumab as one of the new drugs that we have available and how we might deploy it in our treatment algorithm. The caveat being, I don't know, right? So we don't have FDA approval for these drugs yet, and really in a practical day-to-day, we don't yet know how these drugs are going to fit into our practice. But this is just, I think, a little bit of guesswork on how it might go. All right, so history. So I only put the largest clinical trials for each of these drugs, but some had several. We've had a lot of failed drug trials in Sjogren's, dating back decades and decades. So much so that in 2012, the Sjogren's Foundation, which is an excellent foundation, created the Clinical Trials Consortium to get all our smart brains together to say, how can we stop failing? We need success in Sjogren's. I'm going to focus on two trials to talk about why we may have failed in a drug that we think probably works for some of our patients, right? So I'll talk about TEARS and TRACTIS, which are the two phase 3 randomized placebo-controlled trials for rituximab. Now we all see Sjogren's. I'm going to do raise the hands again, and you have to do it like exuberantly so I can see. How many people have used rituximab in their Sjogren's patients? Thanks. Oh, you guys are good. Right, so most of the audience has. And we do it because anecdotally we see a response and we know it works. So why did these drugs fail? They may not be the best drug, right? But let's talk about it. Who did they target? So this goes back to the trial we talked about before, right? Post hoc analyses of some trials show some patients may respond to drugs better than others based on their endotype. That's why endotyping is really important. Inclusion parameters. So we talked about this. The anti-SSA antibody positive has a higher interferon signature. Those patients tend to be more active. So now you're seeing why these inclusion criteria, if we go back to our endotypes talk, really make a difference, okay? Disease activity. So some of the earlier trials, which we'll see, didn't focus on disease activity at all. Because when we think about our Sjogren's patient, the first thing we think of is their profound dryness, pain, and fatigue, right? They don't typically come into clinic saying, my IgG is high, fix me. They come into clinic saying, I'm profoundly disabled by these symptoms of dryness, pain, and fatigue, and others too, of course. Whether you use concomitant medications is also a question. And then, so in addition to inclusion parameters, inclusion, exclusion, which instruments do we use? So I am lucky to be part of this thing called OMRACT, which is really neat, and we try to create clinical trial endpoints for different diseases. So they've done this for rheumatoid arthritis, psoriatic arthritis, and Sjogren's is doing one. And it's all about which instrument or endpoint are you using to measure the disease outcome. So let's look at TEERS and TRACTIS. So again, this is like, I'm a rheumatologist, who am I targeting? These are the patients, and TEERS, I would have said, okay, well, I'll let them be on other meds, right? Most of them are, and I'd want to see that this drug is better than those other meds. And I want them to be really symptomatically burdened, because that's who I see in clinic a lot. And they're the ones who stick with you, right? So they focused on a lot of symptom burden. And then they did try to say, well, we hope that we have also an earlier onset Sjogren's. Like, we don't want someone who's burned out. So they tried to get an earlier Sjogren's. TRACTIS said, I'll allow concomitant medications, but we require anti-SSA or Rho positivity and some salivary flow, which we sometimes say is reflective of some residual gland tissue, like you haven't totally atrophied or fibrosed the gland. And then they also wanted symptomatic patients. And when you look at this, what you see is they're really focused on symptoms. And in Sjogren's, symptoms don't correlate very well with disease activity at all. And so by structuring trials focusing on symptoms, they may have made it more difficult to prove a difference with a drug. May have, maybe not. We need to learn more about Sjogren's. That's what I do all day long. The other thing is the question of the Rho 60, right? So if you have anti-SSA or Rho 60 antibody negativity, that's a very different patient than someone who's positive, as we learn from looking at our transcriptomic studies, right? They just look different. What's causing it, I don't know. Then we have our instruments. So the outcome, the primary outcome in TEERS was an improvement in symptoms, which makes sense, as was TRACTIS. So their primary outcome was looking at, did we make our patients feel better? Which is initially where many of us would start, but we had to totally revise this with our new clinical trial approach because we weren't able to see significance here. And we moved to the SDI. And the SDI, if you're not familiar with it, is 12 domains, and each domain has a weighted score, and it ranges from 0 to 123. That's a huge scale, so anybody who's done these trials knows this. The problem is, 70% of our patients live in the 0 to 5 range. And FC nods, exactly, it's a problem. Our SDI is really weighted heavily, and most patients don't have high SDI. So we moved to that instead, as opposed to these symptom-based measures. Now, there are some exceptions to that rule, and we're trying to figure out ways to structure studies to capture those patients. So we talked about inclusion, exclusion criteria, how we measure the outcome, the instruments, and it could be mechanistic too, right? So rituximab isn't perfect mechanistically. So, right, anti-CD20 targets mature B cells, and it depletes them. But what does that do? Well, when you deplete the B cells, you deplete levels of BAFF receptor tyrosine BCMA, and these usually act as a sump for BAFF, B cell activating factor, also called BLIS. And when you have extra BAFF BLIS floating around, that can target the remaining B cells. The other thing that happens is when you have really low B cell levels, your myeloid cells say, hey, I'm missing some of my friends. I would like more of those B cells, and also make some BAFF. And so what can happen then is you have increased levels of BAFF when you have rituximab deployed in your patients. And this ultimately actually can result in increased numbers of autoreactive B cells. Now I'll show you this graph. So this was studied, this is a trial in humans, and they looked at the percent of B cells in the tissue of the salivary glands in different treatment conditions. So the top here is placebo, and then they have a nice image to show it. I think that's always, I love immunofluorescence, right? So baseline in week 24, placebo looks about the same. But look at this combination of belimumab and rituximab. There's pretty potent depletion of the B cells in the gland tissue. And actually, this was studied by Xavier Mariette. He did a rituximab-belimumab combination study, and so sometimes I actually use that in my patients in certain contexts as well. I don't know if he'll ever do a larger phase study just because it's expensive. As somebody who does these as well, they're hard to do. If you use belimumab alone, we tend not to see that robust improvement, and rituximab alone. There's not really a difference. And so because of this, we hypothesize if you target both pathways, depleting B cell and BAFF, you might be able to overcome this limitation. And that's where ianalumab comes in. So I had to be schooled on this a little bit, so I'm going to school you back because I was chastised. It's not ianalumab, it's ianalumab, is how we say it. Yep, ianalumab. So say it out loud 3 times. That's how I learned every new drug in rheumatology. And it's named after the two-faced god because it has a dual mechanism of action. It is a potent B cell depleter via antibody-dependent cellular cytotoxicity, and it is a BAFF receptor inhibitor. So the goal of this drug, as you can see from how I kind of set this up, is to overcome those limitations that we saw previously mechanistically with rituximab. So they did 2 phase 3 trials, and they call them Neptunus 1 and Neptunus 2. So there's like a Greek-Roman god theme here that I think is really fun. Neptunus 1 was 2 doses, and they did subcutaneously monthly or placebo in 275 patients. And then Neptunus 2, they looked at 3 doses, and they tried to include an every 3-month subcutaneous dose just to see if they could space it out for patients. And in this, we always focus on inclusion, right? So they have Sjogren's by criteria, and this is what we were talking about before, right? They focus on 8 domains for their SjD, so not all 12 domains, right? There. Some preserved salivary flow, salivary function, hopefully, and they did allow background immunosuppression, okay? And they met their primary endpoint in both, an SjD of change from baseline of 1 or 1.3 points. The pooled data was around change from baseline 1.2 over placebo. I don't know the ESPRI results based on the publication we reviewed. And then secondary endpoints, we don't know really what the ESPRI was, but the patient global did improve, which is curious, right? Because that's kind of non-specific. Like, why did they feel a little bit better than placebo? So let's look at some of these data in its raw form. So this is Neptunus 1. Now, what I want you to appreciate, because we'll talk about it, is this gray is placebo effect. We see a really robust placebo effect in Sjogren's, and that's something that I'll touch on again in the telitacicept study that we'll discuss. But this is something a lot of us in Sjogren's discuss, and we just could sit there all day long wondering why this placebo response occurs. Both patients and physicians want to feel better. But you can see that there's a clear separation and that there is a little bit greater increase or reduction in SjD with drug over placebo. And then here's a dose response, which we always, in any research study, we always like a dose response, right? Placebo is in gray, and the orange is every 3 months, and we can see that the monthly ianalumab outperforms the every 3 months. And again, we see a significant change from baseline by their primary endpoint, week 48. Again, that placebo effect is robust. All right, so how are adverse events? Well, overall pretty good. So overall AE rates are a little bit higher in the ianalumab than the placebo, but the infection rates actually were somewhat reassuring, lower in the ianalumab than the placebo. But for 3 things, injection site reactions were higher in the ianalumab group, leukopenia and neutropenia were higher in the ianalumab group. Serious AEs, again, not a big signal here. And the AEs that drove discontinuation were the ones that I highlighted. And so for this reason, if this is deployed, we may want to monitor blood counts for patients on these therapies. All right, so who might benefit from ianalumab? Well, we chose patients who have an SDI greater than or equal to 5, and as we saliently pointed out, in certain domains. Right? So maybe patients who have some of the domains that were excluded may not have experienced that same benefit. But this moderate to severe systemic disease is a good starting place for some of these patients, particularly anti-SSA antibody positive patients. Now, in this study, I should say they did allow SSA negative patients to enroll. It was less than 10% though. And so then, what does that mean, right? If it's a really diluted population, did they see anything in that population? It would be great to get that parsed out and see if they saw improvement there. But I don't know, based on what I know about SA negative Sjogren's, I would guess that probably they wouldn't benefit as much as the interferon strong SA positive. All right, so questions. What other PROs might improve with longer treatment? We saw patient global improve, but what does that mean? Like, why did they say they felt better? Another really interesting question is glandular benefit. Remember those ultrasounds I showed you that had all those anechoic and hype? They're pretty profound, right? And anybody that puts the ultrasound up there, like if you do, you see, I mean, when you have a Sjogren's patient, you know. It would be wonderful if we could see a benefit both in function in most of our patients, which there may be, but also if we could see a change in echo texture. Like, wouldn't it be great if you could do pre-post like you do with synovitis? And you could say, I can see that your gland structure is improving, you're responding to the drug. It would be really cool. Does it work in seronegative patients? I don't know, I can't comment on that. Long-term safety, this is a potent B-cell depleter. So of course I'm gonna be concerned for infections. And then how long are patients treated? Do they get adverse effects over time? And the big question in our patient's mind, would it reduce lymphoma risk? Okay, so I kind of mocked up some general algorithms to walk through, and these are just algorithms for treating different kinds of common Sjogren's manifestations. And then the next talk, I'll do some really fun cases that hopefully, I tried to make it so that by the end of an hour and a half, we're like seeing patients, because that's what our brain needs at that point. Okay, so our inflammatory arthralgias or arthritis. So as we mentioned before, in Sjogren's, we don't tend to get erosions. So when we have mild arthralgias, we start with NSAIDs, and that's sufficient for many of those patients. Of course, we step up to hydroxychloroquine, and then we get, and that, if you remember in the Joker study, failed. That was another failed trial we had, right? Because we used to treat Sjogren's patients with hydroxychloroquine like we treated lupus. But if you recall, it failed. But if you do post-hoc analyses, hydroxychloroquine did have an effect on certain groups of patients, endotypes, if you will. And then, of course, we step up to other DMARDs like methotrexate, leflunomide, sulfasalazine, just like we would with rheumatoid arthritis. And usually I start here if there's synovitis or they're more severe, just like you would, very common sense. You know, if we fail there, that's where we go to our biologics. Right now, I like abatacept if I can get it approved. We can use TNF inhibitors, and rituximab can be nice in that group as well. But soon, now I'm sure many of you do this as well, to get some of those drugs, I diagnose the patient with whatever I need to get them their drugs, right? That's the trick in the United States. But soon we may have an FDA-approved drug where we don't have to go through that rigmarole, right? And that's where we may use one of these new drugs like ianalumab instead of these other stronger drugs. We may hopefully not have to jump through the same hurdles because we'll have FDA approval. All right, so let's talk about sialadenitis. So first off, I focus here on chronic sialadenitis, but with acute sialadenitis, patients get severe swelling and pain in their salivary gland. And the first time that happens, I will have them come in. I don't know if any of you expressed pus from the Stenson's duct. It's really satisfying and it's a fast diagnosis. But especially with severe cases, you just want to make sure they don't have an infection. And all you do is you take your 2 fingers and rub across the angle of the mandible in a, let's see, this would be a clockwise motion. And that expresses saliva into the Stenson's duct. You can see it on the inner aspect of the buccal mucosa right under the line of the molars. And you can see the saliva being expressed normally when you do that. But if you have an infectious sialadenitis, you actually can express pus and culture it right there and then treat the patient definitively. So make sure they don't have an infection if you have acute sialadenitis. And then we treat with conservative measures, right? Warm compresses. We say use your gustatory agents regularly, like our Xylamelts or other sugar-free candies. And then we say sometimes let's try cevimeline to keep saliva, or pilocarpine, whichever one, to keep saliva moving and to reduce the rates of these. Now, sometimes you get chronic sialadenitis. And one other thing I should say, if you have recurrent or persistent sialadenitis, lymphoma should be on your radar, right? And so those patients, I'm definitely doing salivary gland ultrasound, and in the right clinical context, doing the core needle biopsy to diagnose. Okay, so chronic sialadenitis, it didn't get better with conservative therapy, it's bothersome, we move on to hydroxychloroquine. If hydroxychloroquine fails, we move to methotrexate or leflunomide, and I've seen nice response in those. And I should actually mention, so Xavier Mariette, again, did a clinical trial in leflunomide, or maybe it was the Netherlands group. And they actually found with leflunomide hydroxychloroquine combo, we saw an improvement, a trend toward improvement in SjD as well. And so I do see some patients' sialadenitis respond with these drugs, and I think they're reasonable and inexpensive to use. When that fails, then I'll typically move to one of our stronger agents. Usually I use rituximab. Getting it approved can be difficult. And again, this is where in the future, once we have FDA-approved drugs, then we may be able to use one of those in this particular scenario. All right, so lung involvement. We will go through, like I said, a lung case and sort of our diagnostic approach to patients in lung involvement in the next talk. But what do we have? We have 2 kinds of lung involvement. Well, there's more than that. But if we break it into 2 rough treatable branches, we have bronchial involvement, which if it's symptomatic and bothersome, may be treated with inhaled steroids. And then, of course, we have our interstitial lung disease. And interstitial lung disease and Sjogren's, again, we just lack data on natural history, right? Like LIP can be indolent, not all patients require therapy. So it sort of depends on the patient's presentation, their kind of ILD, and their progress. We may monitor in mild cases. We may just give a little bit of glucocorticoid. A lot of the patients I see, oops, I didn't mean to do that. A lot of the patients I see, we tend to have more aggressive disease. And so usually my go-to is mycophenolate, but of course methotrexate or leflunomide, now with the new guidelines as well, azathioprine. In very severe cases, I'll start both at once, like rituximab and these drugs. And again, this is the question, is now that we'll have an FDA-approved B-cell targeted drug, do we move towards like ianalumab if we have a very severe patient? And then I do wonder too, we know from mice studies that ianalumab potently reduces B cells in the tissue akin to the rituximab BAFF combination. So I would hope too that there's better tissue level depletion for these patients who have ILD with these sorts of drugs. But again, it's potent, right? That's a potent immunosuppressive drug, so we want to make sure we're using it in the appropriate clinical context. Okay, so with that, I am going to pause, give some conclusions. Okay, we have for the first time, we have new drugs for Sjogren's that we do expect FDA approval for. These are just some ideas of how I might see them deployed in your clinical practice, but I also don't really know how I'm going to use them yet because I'm interested in sub-analysis, like look within the SjD, which parts of the SjD improved? What are we underpowered to understand? What did we not study? I think we need more data in those particular scenarios. And then again, this clinical equipoise question. There are risks associated with therapy. Who stands to benefit? And that goes back to, again, the importance of an accurate diagnosis for these patients. And with that, I will take your post-test, and I'll take any questions while we decompress for the last Sjogren's talk. I want to make sure everybody has time to do their post-test. Can everybody say ianalumab? Ianalumab. All right. Did everybody?